Very good afternoon, everyone. A warm welcome to all the viewers who are logged in for the today's session, Evolving Concepts in COVID-19. As we know that the whole world has been faced with an unprecedented pandemic of COVID-19, and India too, we are also seeing a very rapid surge of cases. We are seeing a lot of sick cases in our hospitals, and we have been occupied with our COVID work all throughout our days. And during these crucial times, we see that there is a lot of new literature which is coming. There are a lot of new concepts which are coming. As a part of the treatment, a lot of importance has been given to antivirals, controlling the inflammation with steroids and molecules like tocilizumab. And there have been a lot of hypes and hopes on tocilizumab and molecules like itolizumab, control anticoagulation. So all these things. To understand the rational use of different molecules, antivirals, anticoagulation and anti-inflammatory agents, it is important for us to understand the proper pathophysiology of COVID-19 so that we can use all this rationally in our patients. So to explain this in a very detailed manner, we have an esteemed doctor, Dr. Vijay Yeldandi sir. So Dr. Vijay Yeldandi is a clinical professor of medicine and surgery at the University of Illinois at Chicago, and he is an infectious disease specialist who has a keen interest in disorders of the immune system and infectious diseases primarily of the transplant recipients. And he has done a lot of research over the last 3 decades in antimicrobial resistance, molecular genetics and infectious disease diagnostics, HIV epidemiologists, and he has done a lot of work in public health in India too, and he has been a part of the National AIDS Control Organization for the control of HIV and AIDS in India, and he has a lot of publications in the peer-reviewed journals. I think a lot of times when we had complex and perplexing cases, infectious disease cases, I've always referred to Dr. Vijay sir for his opinion and advice, and it has been very helpful. Today in our session too, I think we'll learn a lot from Dr. Vijay's experience and Vijay's knowledge. We are very much thankful and grateful to you, sir, for accepting our invitation and being here. I invite you to today's current session. And to moderate the session along with me and invite Dr. Vijay. So we have Dr. Jagadeesh, who is a consultant in internal medicine, and Dr. Deepika, who is a consultant in pulmonology at both at AIG Hospitals. So we all welcome you to today's session, sir.
Thank you. Thank you very much. I really appreciate the honor and the privilege of interacting with all of you. So without further ado, I will start and try to share my screen with you now. Are you able to all see my screen now?
We are able to see, sir.
Okay. So I will always start with a small prayer. It says, Loka samastaha sukhino bhavantu om shanti shanti shanti. It's a very rough translation, says, in all of creation may joy happen and let there be tranquility. So what I would like to do in the next few minutes is really talk about a few concepts in the pathophysiology of COVID-19. And I'm not going to cover, this is not going to be a very completely detailed, comprehensive review, but just what I think are a few salient things that help us understand what is going on with our patients and what we should do about it. And just before we all get carried away that I'm a great expert, I always like to remind myself of what George Bernard Shaw said about professions. He said, all professions are conspiracies against the laity. So, so take my words for whatever they are worth. I hope they generate some interest and some debate about what is and what isn't. And quite honestly, all the data is there for everybody to see. And very obviously, I bring my own cognitive biases to how I interpret this data and what I think is important and not important. For those of you who are interested, I have the entire presentation on my website, which is happenforonehealth.org. So if you're interested, you're welcome to download the entire slide set from there. So firstly, the coronaviruses, these are viruses that we've known about for a very long time. In fact, the viruses that cause the common cold, apart from the rhinoviruses, about 30% of those are caused by coronaviruses. There are a couple of the alpha viruses, which are the human CoV229E and the human CoV-NL63, which are the alpha coronaviruses. And amongst the beta coronaviruses, there is among group 2A, the human coronavirus OC43 and the human coronavirus HKU1. So we've known about these viruses since the 1960s. We've also known about a whole host of other coronaviruses that cause trouble in animals. So although everybody likes to talk about bats, but really the coronaviruses are big problems in poultry because they cause a very severe infective bronchitis, which is lethal for chicken, for poultry. And also in pigs, they cause a very severe diarrheal illness and a pneumonia. So in the pig industry and in the poultry industry, these are very, very important pathogens that we've known about for a very long time. Now, the newer viruses, the beta viruses that we first learned about was the SARS virus, which belongs to, again, a beta coronavirus. And this was the first time that we saw a virus that had clearly jumped the species barrier from bats to humans and caused a very deadly disease with approximately 8 to 10% mortality due to a very severe pneumonia. And this was followed by the Middle Eastern respiratory virus, the MERS virus, again another beta coronavirus, which jumped from bats through an intermediary host to humans and caused a lot of trouble. So we've known about the basic virology of coronaviruses. We've known a lot about the basic pathophysiology of coronaviruses in many different animal systems. And also there are a lot of animal models. So the research into coronaviruses is over 50 years old, since the 1960s. So a lot of what I will tell you is really not new. It's just that we haven't paid too much attention to it. Now, in the structure of the virus, everybody likes to talk about the spike protein, all right? Because this is the thing that gives the coronavirus its name. It looks like a crown, so that's why everybody talks about it. And it is important because the spike protein is one of the structures of the virus that mediates attachment to the receptors of the cells that it invades. Therefore, everybody's fond of it, everybody's studied it a great deal. People have made lots and lots of antibodies to it. In fact, monoclonal antibodies to the spike proteins are more than 20 years old now. So everybody likes to talk about it. I will tell you that in terms of the importance of the pathogenesis and specifically how the virus actually causes trouble and kills people, the spike protein is not particularly interesting. It is interesting only in the fact that it attaches to the cellular receptor and is probably important for that reason. But in terms of what happens thereafter, it is of marginal importance. What is far more important is the envelope glycoprotein, and specifically what is known as a viroporin 3E protein. We will talk more about that as we go along. So, as you can see on this slide, there are a whole bunch of viruses that are listed in red, and those are all the different kinds of SARS-CoV viruses or the COVID-19 viruses that have been seen. Why is that important? Well, there are a lot of different subtypes, or I shouldn't actually call them subtypes, a lot of different genetic variants of the virus that have been classified and described. So everybody started talking about, oh, the COVID-19 was already mutating into a lot of different viruses. That's not really true. What it is that this particular virus replicates at a very high rate, and that's why it evolves into a lot of slightly heterogeneous genetic populations. Now, so to go back to the bats, so if you look at all of these viruses, starting with the SARS virus, it starts on the bats. The intermediary host was civets, which are a type of wild cat, and some raccoons and dogs, and finally humans, it infects humans. And again, for MERS, the intermediary hosts are camels, and then it infects humans. Now for COVID-19, we have not yet found the exact definitive intermediary host, although there has been one description of COVID-19 infecting minks in Spain, and from minks, the infection being transmitted again to humans. So again, the other really interesting question that we should ask is, why are these coronaviruses infections not lethal for bats? Why do bats happily live with all of these coronaviruses, whereas these coronaviruses, when they cross over to other animal species, specifically humans, can be lethal? So we will come to that question as we go along. So again, like I said, there are a whole host of different kinds of receptors that are found. The ACE2 receptors are important, the TMPRSS2 receptors are important, and for at least MERS, the DPP4 receptor is very important. And lately, there has been yet another receptor described for COVID-19, which is called a neuropilin receptor. So receptors are clearly important, but the important thing to note is that the ACE2 receptors in particular are found all over the body, the entire vascular system, and they are well distributed throughout all different kinds of organs in the human body. So that is why when we talk about COVID-19 infection, it is important to understand that we are talking about an infection that infects every part of the human body. Now, as we go along in terms of understanding the pathophysiology and how that translates into management paradigms, we will go through several different paradigms. The first that I'd like to address is the antiviral paradigm, because as an infectious disease specialist, and most of us, whenever we deal with an infection, we are always fixated on trying to kill the pathogen or eliminate the pathogen. That's why we focus so hard on antimicrobials, and in this case, antivirals. And I would like to persuade you that that is not the entire story, and focusing solely on the antivirals is not likely to be of great utility in clinical management. The next paradigm is a cytokine paradigm, because we have now begun to understand the consequences of infections much better. And for the last 40 odd years, we have focused in particularly in septic shock, whether it is caused by a bacterium or a fungus or a virus, on cytokines and the cytokine mediated storm that occurs in the human body and the failure of homeostatic mechanisms. Now the cytokine paradigm, I think, is quite important. However, it is not the entire story. Now, for the last 10 years, we have started focusing on yet another science or discipline, and this is called the science of inflammasomes, which is how inflammatory changes occur in the body. And these inflammatory changes are not necessarily all mediated by infections. There are a variety of different ways by which these kinds of inflammation inflict organ damage in the human body. And the central feature of all of this is protein complexes that we now call inflammasomes. And there are many different kinds of inflammasomes that are described, and it will take very long for us to go through all of them. So I will restrict myself to very specific inflammasomes of interest to us in COVID-19. The importance of understanding the science of inflammation is that inflammasomes appear to be very important in mediating organ damage, and indeed they are also very important in mediating the release of cytokines that cause trouble. Finally, I think what we have to do in practical clinical management of COVID-19 is integrate all of these paradigms into a practical clinical approach. The antiviral paradigm, the cytokine paradigm, and the inflammatory and end organ damage paradigm. Now, when we look at the Wuhan experience, what we find is, if you look at all of the people who have very severe disease due to COVID-19, there are a few things that are of very notable importance, and in fact, these have now been accepted as important things to look for in trying to stratify those people who are likely to get into a lot of trouble. The first amongst these is an absolute lymphopenia. The absolute lymphocyte count, particularly when it goes down below 800, is a bad prognostic sign. It is associated with quite severe disease. The next is a reduction in all sorts of T cells, but in particular NK cells, because natural killer cells are part of innate immunity, which are exceedingly important in defenses against viral infections. So there is a decline in all sorts of T cells, but particularly NK cells, and also a lot of Th, CD3 and CD4 positive cells. There is a marked decline, particularly in those people with the most severe illness. Very interestingly also, in the people who have the very severe illness, there is a marked increase in ferritin. Now, ferritin, increase of serum ferritin, is a marker for activation of macrophages. And we see it in every syndrome where there is a lot of macrophages that have been severely activated, and these activated macrophages then lead to the cytokine storm. We'll talk about that more. Now, this is a very interesting cartoon to try and remember, because what it shows, and I'd like for you to focus on the viral load part. So typically, in people who get infected, they are experiencing an increase in the viral load, and very typically the viral load peaks a couple of days, starting a couple of days before they are symptomatic to a few days after they are symptomatic. So the median high viral load that is seen is about 5.1 days before they are symptomatic and about 5 to 10 days after they are symptomatic. But what is important to focus on is that the viral load declines in almost everybody, regardless of whether it is a typical course, it is a fatal course, or it is a severe course. The viral load actually declines, which means that the body has the ability to restrict viral replication. What the problem is that during the process of restricting the viral replication, there is a severe inflammatory syndrome mediated by cytokines and inflammasomes, and this is a thing that really influences whether there is recovery or there is death. So this is an important concept to understand, because here is another thing. In the clinical course of an individual, when we look at the timing of different kinds of treatment in relation to the onset of symptoms, we have come to understand that antivirals are probably most helpful very early on. There is probably a role of convalescent plasma very early on and not later on. Immunomodulators certainly come in when somebody is beginning to show signs of inflammation, and adjuvant treatments. Now, just a word about convalescent plasma. It is not at all clear why convalescent plasma might work or may not work. So therefore, it is not very easy to understand why convalescent plasma has been shown to work anecdotally, yet we do not have convincing evidence from controlled clinical trials that convalescent plasma really adds to the benefit of managing critically ill patients. So there is still a lot of controversy about exactly what we are doing with convalescent plasma. I would suggest to you that this notion that convalescent plasma is providing a large quantity of protective neutralizing antibodies is suspect, because simply the amount of antibody is nowhere near the titer of the amount of antibody that we have used successfully for other infectious diseases. For example, we have used very high titer monoclonal antibodies or artificially created antibodies against infections like anthrax, infections like Ebola, infections like respiratory syncytial virus, although for RSV, it is only for protection and not for treatment. And anecdotally for some other things like the cytomegalovirus, etc. And here you must understand the amount of antibody, specific antibody that we use targeted against those pathogens is a very, very high titer. That is nowhere near what we see in convalescent plasma. So really, what are we providing with convalescent plasma that provides benefit? You must understand that convalescent plasma has a whole lot of other constituents in it other than antibody. Part of it may be things like ADAMTS13, which is von Willebrand factor proteases. Part of it may be complement control proteins and so on and so forth. Nevertheless, we still have to see exactly where convalescent plasma comes in. Is it really convalescent plasma that's important with the antibody in it? Or is it simply just supplying fresh frozen plasma that would do just as well? That is yet a question that needs to be answered. Now let's go back to viruses on antivirals. Now, for the longest time, we all understood that viruses really do not directly damage tissue. Okay, you cannot show that a virus goes and degrades tissue by itself directly. Like for example, if you saw a mixed synergistic gangrene due to bacteria, you can show that these bacteria destroy tissue, they actually cause tissue destruction. Or angioinvasive fungal pathogens like aspergillus or mucor, which actually go and destroy tissue. Viruses don't do that. In fact, it is very hard to show how viruses can actually, even very large quantities of virus can actually physically do damage to any part of the body or any tissue. So for the longest time, for a lot of viral infections, we always had this debate. Is it the virus or is it something else? In fact, this was a great debate in the early days of the HIV. A very respected virologist called Duesenberg constantly said, look, it has nothing, the virus has nothing to do with it. It's actually the body's own inflammatory response that causes AIDS. Until David Ho showed that it was the virus, because this virus multiplied into such large quantities. But more importantly, if you brought down the number of viruses and you reduce the viral population to practically undetectable levels, the immune system would reconstitute. So that's why he appeared on the cover of Time magazine in 1996, and he said, well, it's the virus, stupid. You know, he was paraphrasing Bill Clinton's famous election slogan, it's the economy, stupid. So, viruses. Now, what is important to understand about COVID-19, and we touched about this early on, that COVID-19 is an RNA virus that multiplies into very, very large numbers. In fact, the viral load, when you look at it in nasal or nasopharyngeal specimens with RT-PCR, can reach over 1 million copies. This is a very large number of viruses. This is an RNA virus. Any RNA virus that replicates into such large numbers eventually becomes what we call a viral quasi-species. This is a concept that was first propagated by Manfred Eigen in the late 1980s. You know, when I was in training, in fact. This is long before anybody had thought about using multiple antiviral agents to treat HIV, and the notion of highly active antiretroviral therapy wasn't even known. And Manfred Eigen, just using mathematical modeling, predicted that HIV is a viral quasi-species and could not be treated with one antiviral agent alone, because in any viral quasi-species, you have a very large population with lots of subpopulations. And these subpopulations have enough genetic heterogeneity to be able to evade any agents that are trying to prevent the replication. That is why in HIV, we cannot use one antiviral agent alone. Over a period of time, that population selects out a resistant subpopulation that replaces the entire population. In fact, HIV replication is so high that the entire population is replaced once every 3 days. The same is true of COVID-19. This is a virus with an extraordinarily high replication rate. Therefore, one antiviral agent, particularly an antiviral agent that targets the RNA-dependent RNA polymerase, which is what the currently approved antivirals do, like remdesivir and favipiravir. They go and obstruct the RNA-dependent RNA polymerase. That strategy is doomed to failure, in my opinion, because a single mutation will render that enzyme resistant to the action of either remdesivir or favipiravir. And for this reason, if we are to use antivirals, I think that an effective antiviral agent will require us to use two different agents in combination, preferentially agents that act at different sites. So it cannot be both the agents acting at the RNA-dependent RNA polymerase site. It has to be, one can be a polymerase site, one has to be some other site, okay? And that's what people are working on, by the way. And indeed, this would have become extremely important, but for the fact that the human body is actually able to stop the replication of the virus in everybody. Even in the people in whom there is fatal illness, viral replication goes down, the viral titers go down. So therefore, we have not found it absolutely imperative to have an effective antiviral strategy. And for this reason, if we are to use an antiviral, it is probably used only in the early stages of the infection. It probably becomes irrelevant at the later stages of infection when the body has already controlled the replication of the virus. And the real reason the human body is in trouble is the inflammatory response. So just to go back to this antiviral story, here's a plethora of different targets that people are looking at to interrupt the viral life cycle. And this slide is not meant to be actually read by you. I'm just to remind me at how many different sites of the viral life cycle people are looking at to try and interrupt the viral replication, and the plethora of different agents that have already been tested for in vitro activity against the virus. Just humongous, incredible number of substances have been tested in the laboratory with a variety of different things. And fortunately, nowadays, we actually don't wait for the traditional plaque reduction assay system. We use quantitative RT-PCR to see if there is a decline in the viral population, to see if that compound is effective as an antiviral agent or not. And I will tell you that there is a very large number of compounds, some of which are experimental and some of which are actually approved drugs that show excellent in vitro activity against the virus in the test tube. A good example is hydroxychloroquine and chloroquine. Now, that was one of the reasons why everybody thought hydroxychloroquine and chloroquine would be wonderful. Unfortunately, that has not panned out. Now, so the key therapeutic classes that are now under investigation, there are a whole bunch of antivirals, baloxavir. We talked a little bit about convalescent plasma, favipiravir, hydroxychloroquine, a bunch of interferons, particularly interferon beta, lopinavir, ritonavir, nitazoxanide, which is a very interesting compound because it gets converted into T-zoxanide. And T-zoxanide not only has good antiviral activity against COVID-19, it actually inhibits IL-1 and IL-6 also. Oseltamivir really doesn't have any activity. Remdesivir we'll talk about. Ribavirin has activity in vitro but has not panned out in clinical trials. And amongst the immunomodulators, people have tried corticosteroids, IL-1 inhibitors, IL-6 inhibitors, IVIG, intravenous immune globulin, and also the Janus kinase inhibitors. So a whole host of different kinds of strategies have been looked at. So here's a summary of some of the most important trials that have been done to date. Lopinavir, ritonavir, no impact in multiple studies. Remdesivir, the first study, really did not show any great benefit. Next study, remdesivir 5 days versus 10 days, no difference. Now, people have interpreted this to mean that remdesivir for 5 days is just as good as 14 days. I would interpret it to say that remdesivir for 14 days is no better than 5 days. So it depends on whether you ask whether the glass is half full or half empty. Favipiravir against umifinovir, which is not, umifinovir is a very interesting compound because it does not work by suppressing the RNA-dependent RNA polymerase. It works through a very different pathway, which is the clathrin pathway. And interestingly, it is one of the few compounds that actually upregulates interferon production intracellularly, which may be very important in viral infections. Then hydroxychloroquine. Again, hydroxychloroquine to date in the first study is one French study that showed some benefit. Again, further studies did not show any benefit. Now, a much larger study with remdesivir, over 1,000 subjects. And here we did see that there was some benefit in terms of recovery, but no benefit in terms of overall mortality. Now, this is very important to keep in mind. Mortality is the hardest endpoint. It is a dichotomous variable that we always look for. It really doesn't matter how wonderful you think the drug is. If you have used the drug and you say, my patient got out of the ICU, well, he may have gotten out of the ICU, but did he go home alive? That's the key question. So always look at mortality. And clearly, remdesivir to date has not shown a clear benefit in mortality. Tocilizumab, again, very mixed data. Some data suggesting that it might work, some data that suggests that there is no clear advantage. In clinical trials has not yet shown a definitive advantage. Still, this drug is an interesting drug, and I think we are still learning how to use IL-6 inhibitors. Now, one word of caution about IL-6 inhibitors, whether it's tocilizumab or itolizumab, the problem with IL-6 inhibition is that you increase the risk of other infections. Clearly, there have been case reports of increased risk of fungal infections, bacterial infections in the ICU, but also reactivation of things like Mycobacterium tuberculosis, fungal infections, as well as cytomegalovirus. So all in all, tocilizumab or itolizumab, IL-6 blockers are not a benign agent to use. And also, if you think about the pathogenesis, if you have to use it, you have to use it early on, not after somebody's already landed on a ventilator. Sarilumab, again, not a great evidence of a decrease in mortality as yet. Now, this is something that we should pay attention to, the recovery trials. Why is it important? What is important about the recovery trials is they are well designed, very well designed, scientifically well designed, but most importantly, they have large numbers of subjects. And this is the key. The biggest criticism that I have of all of the published studies with COVID-19 is they're very small. And there is no way on earth that these small studies really truly represent the entire population at large because of the tremendous biologic heterogeneity that we see. And therefore, a small study, particularly when it is looking at soft endpoints, like say improvement in viral reduction of viral titer or improvement in days to clinical resolution and so on and so forth. These are what I call soft endpoints. And we really should be very careful about these soft endpoints, particularly when they are coming from trials that are just a couple of hundred subjects. So therefore, this is the importance of the recovery trials, large numbers across multiple sites, and very well done, very well designed trials. So the evidence that comes out of the recovery trials is, in my opinion, definitive. Now let us look at what they saw in hydroxychloroquine. They had to shut down the trial because even after enrolling thousands of subjects, there was no benefit, no clinical benefit whatsoever. However, very interesting, the dexamethasone trial was halted for exactly the opposite reason. They saw benefit and it was no longer ethical to continue with the trial because of the clear benefit. And what we find with the dexamethasone study is that there is a clear benefit. And in fact, this is the number really to pay attention to. It says that if you treat 8 patients who are on a ventilator with dexamethasone, you will prevent 1 death. So, well, the 7 other patients you gave it with no great benefit, perhaps some of the downsides of the side effects of dexamethasone, but clearly 1 out of 8 patients was saved, okay? And in patients who are not on a ventilator, it was a larger number of patients that you had to treat to show benefit. In fact, you had to treat about 25 patients to show benefit. So that is the importance of the recovery dexamethasone trial. And in fact, this is very interesting because it makes sense when you look at why dexamethasone should work pathophysiologically, and I will come to that in the next few slides. So, this is a very interesting paper that comes out of China, and what these people did is they used modeling of the structure of the virus and the structure of hemoglobin to suggest that the virus would directly attach to hemoglobin, both oxidized and non-oxidized hemoglobin, and reduce oxygen delivery. Now, be careful, this is all in silico modeling, but it's intriguing because of the phenomenon that we see in a lot of people with COVID-19 that we call the happy hypoxemics. They are clearly hypoxic, but they are not symptomatic, they are not dyspneic. Very interesting phenomenon. So this is sort of something akin to, say, methemoglobinemia, where again we see that, when you look at the amount of oxygen delivery capability and the patient's symptoms, there is a clear disconnect. Anyway, this is an interesting and intriguing thing, but whether it's clinically relevant or not, we do not yet know. Now, very early on, a lot of people said, based on the prior experience with SARS and also MERS, that something very similar is happening with COVID-19. And of course, there's this nice paper from Pedersen and Associates that showed that in the sickest patients, you had clearly an increase in IL-6, LDH, D-dimer, CRP, and ferritin, and also a bunch of other pro-inflammatory cytokines. So clearly, there is an association, if not a cause and effect. And again, yet another study that showed pretty much the same thing with IL-1 beta, IL-2R, IL-6, IL-8, IL-10, and TNF-alpha. When you look at the most severe cases to the less severe cases, there is a clear difference, statistically significant. Now, the other very interesting thing is IL-18. Why is IL-18 so important? IL-18, both physiologically and also diagnostically, is the cytokine that is responsible for activating the macrophage activation syndrome. This is very, very clear. So it is the single most important cytokine vis-a-vis the macrophage activation syndrome. And we will come to why IL-1, IL-18 are extremely important in COVID-19. So what happens when you have the macrophage activation syndrome? Well, what you have in the macrophage activation syndrome is that through a variety of different triggers, whether it is the macrophage engulfing red cells or engulfing other hemoglobin degradation products, or it is being activated by cytokines like IL-18 or other mechanisms, whatever the mechanism is, these macrophages eat up all of these things, and then they start making oodles and oodles of cytokines that cause an inflammatory reaction. Specifically, they cause activation of the Janus kinase systems that will cause a STAT system to be activated and a whole lot of inflammatory cytokines to be produced, which are all dependent on nuclear factor kappa B dependent system, and all of these inflammatory cytokines eventually cause a lot of damage and cell death. Now, when we talk about cell death, there are several different kinds of cell death, okay? The cleanest kind of cell death is what we call apoptosis or programmed cell death, where there is no inflammation. The entire nucleic acid of the cell is degraded by caspases, and the cell is digested and autolyzed, and there is no inflammatory reaction. That is called apoptosis. But for us, what is relevant is not apoptosis necessarily, but necroptosis, where there is a huge amount of necrosis of the cell. There is widespread damage, and in particular what we call pyroptosis, because along with the necrosis there is a release of a lot of inflammatory cytokines that cause severe inflammation in surrounding tissues and in the entire body in particular. Now, the key feature of a macrophage activation syndrome classically was what we call the hemophagocytic lymphohistiocytosis syndrome. And this has a lot of diagnostic criteria that you have to meet. You have to have at least 5 of all of the following: fever, splenomegaly, cytopenias, anemias, thrombocytopenia, neutropenia, high triglycerides, depletion of fibrinogen, and to show the actual hemophagocytosis in bone marrow biopsies, but very interestingly, very high ferritin. Now, this HLH is actually an extreme manifestation of the macrophage activation syndrome. So if you look for all of these criteria, you're not going to find it. What we are going to find in our patients is several features of the macrophage activation syndrome that manifest as a lot of ferritin around, a lot of cytokine release, and the entire spectrum ranging from thrombotic microangiopathy all the way to thrombotic thrombocytopenic purpura. So you have to look for all of those. Don't insist on the entire diagnostic criteria of HLH. You're going to miss a lot of your patients in having trouble. And in COVID-19, this has been well described. The macrophage activation syndrome is well described. Now, the macrophage activation syndrome is not unique to COVID-19. We have seen it with a whole bunch of other viruses. We have seen it with influenza viruses. We have seen it with Epstein-Barr virus. We have seen it with hemorrhagic fever viruses. We have the Congo hemorrhagic fever virus. We have seen it with a whole host of other viruses. I have seen it particularly in my own megalovirus, where I had a patient who was a small bowel transplant who manifested with CMV disease and also had profound macrophage activation syndrome with thrombotic microangiopathy, did not meet criteria for HLH, so I could not persuade the hematologist to give her any treatment. They said, no, it's all infection, treat the infection, she'll get better. I did. I gave her lots of ganciclovir, she did not get better. The CMV was completely suppressed, but she did not get better. She kept on having thrombotic microangiopathy, and the hematologist even refused to plasmapherese her. So out of desperation, I started giving her fresh frozen plasma. And she responded beautifully to that. Because what happens in macrophage activation syndromes is you get a diffuse inflammation of the entire endothelium, and you get depletion of von Willebrand factor proteases, and you also get activation of complement and complement-mediated damage. So what fresh frozen plasma does is it replaces the von Willebrand factor proteases. It also replaces a lot of complement control proteins, and that's what eventually leads to the reduction of the syndrome. And in TTP, of course, because they have antibodies to ADAMTS13, you have to actually plasmapherese them to remove the antibody and then give them fresh frozen plasma to replace the von Willebrand factor protease, and that's how it works. So this is an important concept to understand in COVID-19 associated macrophage activation syndromes. Now, what is the treatment? The first line, of course, is dexamethasone. Isn't that interesting, guys? We see that dexamethasone clearly helps those people who are on ventilator and struggling. Why does it do that? Because these are people who have macrophage activation syndromes. They may not meet all of the criteria of HLH, but they do have a macrophage activation syndrome, which is why some of them respond to dexamethasone. Can you use methylprednisolone? Yes, of course you can. Can you use cyclosporin? Yes, of course you can. My problem with those agents is, in particular, agents like cyclosporin and tacrolimus, those are also known to trigger thrombotic microangiopathy, and methylprednisolone is not better than dexamethasone in anti-inflammatory activity, but it is certainly worse than dexamethasone in immunosuppression. What are other alternatives? You can use high-dose intravenous immunoglobulin. People have tried etoposide, cyclophosphamide, plasma exchange we talked about, and antithymocyte globulin, but most interestingly, anakinra, and that has actually worked. And that becomes very significant, as we will talk about in the coming slides. Now, this is a very interesting paper, which is an animal model of MERS-CoV, and the reason why it is important will become evident in the next few slides. And what they looked at is, firstly, they created a transgenic mouse that expressed human DPP, because for MERS, the DPP4 receptor is important for infection. And what they showed is that when they sectioned the MERS-CoV infected lungs, they could see deposition of a lot of complement in the tissue, particularly the terminal attack complex of complement. And this was statistically significant when they looked at the mock infection versus the actual infection. And the same was true in infiltration of macrophages and the production of a whole bunch of cytokines in the animal model. So you can see that in those models where there is infection, they have a lot of production of cytokines, IL-1 beta, IL-6, TNF, and so on and so forth. But what is very interesting is that, and this is all the lungs, and if you use a agent to block complement by blocking C5, okay, then there is a reduction in the amount of complement terminal attack complex deposition in the treated animals versus the sham animals. All right, so clearly the amount of tissue damage is attenuated in these infected animal models if you use something to block the common pathway for complement, which is C5. Not only that, what is very interesting to note is that the amount of virus that is seen in the tissues is also reduced when they use C5, which suggests that it is the virus and antibody together that is being deposited in the tissues that is activating complement and causing damage by activating the terminal attack complex of complement. Now, this is very interesting because in human kidneys, in autopsies, we see the same thing. We see a lot of deposition of terminal attack complex of complement along with CD68, CD8, and CD56 in the kidney tissues when you see as compared to normal healthy kidneys in COVID-19 infections. Clearly, there is terminal complement mediated deposition and damage to the tissues. Now, is that relevant to the human experience? And here is a case report of eculizumab, which blocks C5. That is a common pathway for complement, terminal complement activation. And these people, these patients who got eculizumab all improved. Now, eculizumab is very interesting. It is the first monoclonal antibody that is a designer antibody designed specifically to block C5 based on the structure of C5 itself. It is a very interesting compound because eculizumab we have used very successfully in other instances, clinical problems, wherever we have encountered thrombotic microangiopathy and terminal complement deposition, particularly in kidney transplants and particularly in the atypical hemolytic uremic syndrome. It is a really, really wonderful agent and is extremely powerful, and it reverses the entire damage very nicely. The only problem with eculizumab is that it causes a defect in Neisseria host defenses. So people who get eculizumab are very prone to Neisseria meninge infections, all Neisserial infections, for at least a year after the last dose of eculizumab. And therefore, all of these people need prophylaxis with penicillin, or if they are allergic to penicillin, with some other agent that will be active against Neisseria. And unfortunately, giving people meningococcal vaccine prior to giving them eculizumab has not worked either. So if you give anybody eculizumab, you have to give them prophylaxis against Neisserial infections. But very interesting phenomenon here. Now, let's look at viral infections and particularly COVID infections. What happens in all coronavirus infections is that the early host defense is an innate host defense because this is a virus to which you don't have pre-existing immunity. So innate host defense becomes very important. The most critical part of the innate host defense is interferon production. Early interferon production and early activation of NK cells is extremely important for controlling the virus replication and preventing a runaway inflammatory response. So what happens is in these people who mount an effective response, they make lots of interferons. These interferons are able to suppress the replication of the virus. And although there is interferon-mediated activation of the intracellular inflammatory responses and cytokines, these are of moderate amounts, limited quantities, and they are rapidly neutralized later on. So you land up with protective immunity without significant host damage. As opposed to those people in whom there is no interferon response, they get robust ongoing virus replication and activation of the inflammatory cascade and cytokine storm, and ultimately death due to acute lung injury and acute kidney injury and death. So this is a very important concept to understand, that the early interferon response is vital. And this is one of the reasons why we were never very comfortable with the use of hydroxychloroquine, because unfortunately hydroxychloroquine changes the pH of lysosomes intracellularly, and that abrogates the early interferon response. So if anything, hydroxychloroquine will cripple the early interferon response, which is so very important for controlling virus replication. Also, quite honestly, there are a lot of other reasons why we know hydroxychloroquine would not work, because it's been studied in other coronavirus infections and other viral infections, both as an antiviral agent and as an immunomodulatory agent, and it did not provide any benefit whatsoever. Now, if you think about all of these things, then you say, look, what we really need to have in our armamentarium is agents that will block IL-1, anakinra, canakinumab, IL-6 like tocilizumab, itolizumab. IL-18 unfortunately is not available, but also Janus activating kinase inhibitors, tafastinib and other agents like it. All right. So this is very interesting, and people have actually looked at it. And in fact, I will show you some data that shows that this does make sense and it has provided clinical benefit. Now, why is this so very important? And if you look at, this is a cartoon that shows where all of the different things will work. So the JAK inhibitors, for example, will work at the level of STAT and prevent nuclear factor kappa B activation and then the release of a whole lot of active cytokines, particularly IL-1 and IL-18, whereas other agents will work at different sites. Canakinumab and anakinra will work at the IL-1 site, and then tocilizumab and sarilumab will work at the IL-6 site. So this is the cartoon that explains schematically where these cytokine blocking agents might work. Now, what are the therapeutic implications of understanding the role of cytokines? And a lot of this comes from our experience with using cytokines in septic shock. For example, the large prowess trial where we looked at anakinra and it failed in septic shock, except in a very small subset of people, 50% of those subjects had marked improvement with anakinra. And when they analyzed that subset, what they found was that was a subset that there was a lot of IL-1 activation and a lot of macrophage activation. And that explains why in those people, anakinra may have worked. But we have used cytokine blockade in the past in septic shock and it hasn't worked. So what is very clear is that what becomes important is just using cytokine blockade as and when you please will not work. And I just told you that tocilizumab does have a downside. If you use it too late, A, it will not work, and B, it will cause the patient to become susceptible to fungal infections, particularly Candida and other bacterial infections that will eventually kill him. Now, the early interferon response and the early inflammatory cytokine response are part of the innate host defense against viruses, and it's very important not to block it, because the delayed interferon response actually leads to the cytokine storm. And it is the early clearance of the pathogen that is necessary to prevent the cytokine storm. However, we have known for a long time that prophylactic use of tocilizumab actually causes more infections. So you cannot use this cytokine blockade strategies as prophylaxis or to try and prevent COVID-19 infections. So the key is a timely intervention, when to use IL-1 blockade, when to use IL-6 blockade, and when to use eculizumab is something that we need to understand. And it may be that one agent alone will not work. You have to use multiple site blockade. But a proper selection of the individuals who might benefit is really, really important. So what do I look for? I look for the macrophage activity. And to me, the most important thing is an absolute lymphocyte count of less than 800 and a ferritin of greater than 800, which is what I use as a rule because these are the people that I know are at the highest risk for getting into trouble with the macrophage activation syndrome and cytokine storm. Now, people have also used genome-wide association studies to look at other risk factors. And what is very interesting is, just like any other infection, the blood groups are very important. We've known this for a very long time, that what kind of blood group you have is a risk factor for what kind of infection you might get. And clearly, again, for COVID-19, it is very clear that blood group A has the highest risk and blood group O has the lowest risk. Now, what is very interesting is that all of the people who have blood group A are also the people who make a lot of very high levels of Quanfelaprant factor. And this becomes very relevant, and I will go on to tell you why. In any case, whatever we are doing with cytokines and cytokine blockade, I think we need controlled clinical trials to figure out exactly how they should be used, where they should be used, and most importantly, where they. Now, other agents. Now, what is very interesting is statins. Now, what statins do is they reduce inflammation. How they reduce inflammation? There are a lot of very, very, very interesting ways that they reduce inflammation. And probably for COVID-19, one of the most important ways that statins attenuate inflammation is that they block the activity of what we call the high mobility group box 1 molecule. This is a molecule that is very important in what we call inflammation caused by danger-associated molecular patterns. So, high molecular weight group box 1 is a molecule that is actually blocked by statins. But statins also block the prenylation pathways, and the prenylation pathways are very important for the intracellular transport of many viruses, including COVID-19. Okay, so the statins may actually work both as an antiviral and also as an attenuator of the inflammatory response. Very interesting. Now, here's another study with several patients who people gave famotidine to. Now, why would you use famotidine? Very interesting. We've all used H2 antagonists in people who have all sorts of allergic rashes and things like that, because we learned long ago that whatever you think about its ability to reduce acid in the stomach, that's completely irrelevant. The real reason why H2 antagonists actually work in reducing ulcers is that they're anti-inflammatory. They actually reduce the number of immunoreactive cells in gastric submucosa, and they also attenuate the release of inflammatory cytokines by these cells. This is why H2 antagonists actually work, and this is why when somebody has a bad rash, particularly when they have urticaria, we use a combination of an H1 and H2 blockade. Very interesting. In people who have COVID-19 infection, when they were given famotidine, they had symptomatic relief, which makes sense because, again, COVID-19 causes a severe inflammatory reaction, and many people with COVID-19 get all sorts of skin rash, which is mediated by immunoreactive cells within the submucosa or the subcutaneous area. Now, let's get back to cytokines. Now, we all talk about tocilizumab, and I know all of you guys are using tocilizumab, and collectively all of you have blown up several crores of rupees on tocilizumab. Not only that, I have heard of anecdotes where the patients are buying tocilizumab in the black market and are coercing the doctors to infuse it into their loved ones. Amazing. Now, the rationale for use of tocilizumab, of course, is that you will block IL-6. But is that really important? Now, this is an opinion that was written, an editorial that was written just a couple of weeks ago, published a couple of weeks ago in JAMA, and they point out some very interesting facts. Yes, when you look at people who have very severe COVID-19 infection compared to people with milder infection, their IL-6 levels are certainly higher. No question about it. But when you look at the absolute levels of IL-6 that are seen even in people with very severe COVID-19 infection, they bear no comparison to the levels that we see in other people with ARDs. So one should really question how important is IL-6? Is it really the cause of the cytokine storm, or is it simply an epiphenomenon that we are seeing, which is not the real story, but simply a side actor, a peripheral phenomenon that we are seeing pari passu with the rest of the cytokine storm? I think this is a very important question that does need to be answered. What is the role of IL-6, if any? Is it really as important? Now, let me go back to the molecular basis of shock and septic shock. And what we understood a few years ago is the mechanism by which the body causes all the trouble. Because Dr. Lewis had written decades ago that it is not the pathogen per se, but our own body's reaction that is causing this incredible amount of destruction of the body, and that's what's killing people. And the molecular basis of this really did not become apparent up until just about 10-15 years ago, when we started understanding the role of what we call pattern recognition receptors, of which some of the most important things are toll-like receptors and CLRs and RIGs and other things like that. And what these pattern recognition receptors do is they recognize substances that are noxious to the cell, whether these substances are parts of another invading pathogen like a cell wall, like lipopolysaccharide, or some toxin, or even RNA or DNA. And the moment they recognize these, they activate a cascade of events intracellularly that activates lots of cytokines, complement, coagulation activation, and finally, necrotic cell death. Now, this is very important. Necrotic cell death or pyroptotic cell death as opposed to apoptotic cell death is very, very important, because in apoptotic cell death, it's a clean cell death. There is no inflammation. The cell just quietly dies and is disposed of neatly and cleanly by the body's scavenger system. Not so in a necrotic cell death or a pyroptotic cell death, in which you have an incredible amount of release of inflammatory cytokines that activate all sorts of things in the body, cause hypotension, cause organ dysfunction, and eventual death. Now, the mechanism by which all of this happens is very, very important to understand, and is very relevant to COVID-19 infections in particular. So the pattern recognition receptors, they recognize several things. One of them is called a pathogen-associated molecular pattern, which are the constituents of bacteria or viruses or other pathogens, such as lipopolysaccharide or exotoxins or whatever. But the pattern recognition receptors also recognize other things like oxidative stress, like hypoxia or other stress things, and they activate simultaneously the nuclear factor kappa B system that goes and activates the transcription and translocation and the translation of a whole host of different kinds of genes. And they activate a lot of inflammasomes that activate a lot of things like gasdermin D that pokes holes into the cell wall and eventually causes that cell to die. But it releases a lot of other substances that we call danger-associated molecular patterns, of which a very important component is the high mobility group box 1 kind of danger-associated molecular pattern that activates neutrophils. What neutrophils then do is they extrude out of the neutrophil what is called a net or neutrophil extracellular trap. This traps a lot of the substances that need to be cleaned up, in particular nucleic acids, and it also causes ongoing damage in an inflammatory manner because it releases a lot of inflammatory substances. So in any kind of sepsis, DAMPs, PAMPs, nets are very, very important. So the things that we have to remember are things called the high mobility group box 1 molecular group, the gasdermin D that pokes holes into the cell, and so on and so forth. Now, one of the most important inflammasome that we have learned about is what is called NLRP3. And this is very recent. We have learned about a lot of inflammasomes. What inflammasomes are a bunch of proteins that together oligomerize and then create the conditions for activation of a lot of enzymes, particularly caspases, that proteolytically cleave things like pro-IL-1 beta, pro-IL-18, and activate other DAMPs and PAMPs, and activate things like Gasdermin D, activate things like high mobility group box 1, and cause more damage. So there are a variety of different kinds of inflammasomes that are described. NLRP3 is, for our purposes, the most important because this is the inflammasome that is most relevant in viral infections, in particular COVID-19 infections. So what happens is, again, there's a two-signal system. There is one signal that when a PAMP or a DAMP comes to a toll-like receptor, directly activates the nuclear factor kappa B system, which goes and starts the genes producing pro-IL-1 beta and the pro-IL-18 beta, and then the second signal, which activates the oligomerization of a whole bunch of different things that again become NLRP3. And what NLRP3 eventually does is it activates caspases that proteolytically cleave pro-IL-1 beta into IL-1 beta and pro-IL-18 into IL-18 that go on to be extruded out extracellularly and cause further damage. So why is all of this there? NLRP3 and this system of recognizing DNA, RNA, or other proteins as part of the innate host defense system. This is teleologically very, very old. It is conserved across many, many different species, and this is required for cleaning up all sorts of RNA, DNA, histones, any and every kind of different kinds of antibodies. How did it come about? Probably came about when mitochondria became symbiotic with eukaryotic cells millions and millions of years ago, and excess amount of mitochondrial DNA or mitochondrial enzymes or anything else had to be prevented from damaging the rest of the cell. So the cell created the systems to contain all of this. Now, this becomes very important in viral infections because, like I said, these two signals, signal 1 and signal 2, all of them combine to produce NLRP3, and then NLRP3 mediates the downstream signaling of production of a lot of substances that will cause direct damage to the cell wall, in particular Gasdermin D, and in particular things like IL-1 beta and IL-18 that activate macrophages and cause the macrophage activation syndrome, activate neutrophils, and so on and so forth. Now, viruses, of course, have evolved many different strategies to evade NLRP3. And this is very important to understand. So a whole host of different viruses produce different kinds of proteins that try to inhibit the formation of NLRP3. And how well they do it is important in the pathogenesis or the virulence of the virus or the ability of that virus to infect human cells or any other mammalian cells for that matter. So this again is a summary of what we already talked about. There is signal 1 and there is signal 2. Signal 1 goes directly and activates nuclear factor kappa B, activating IL-1 beta and IL-18, whereas signal 2 goes through the NLRP3 system. Now, what I want you to pay attention to is a very specific part of the COVID-19 virus. Now remember, in the beginning of the talk, I had talked about everybody being fascinated and fixated on the spike protein. Now the spike protein is important for attachment, but after that the spike protein is completely irrelevant. Whether you have the spike protein or not is not going to do anything. But viruses, and a variety of different viruses, have another part of the cell wall, a non-structural protein of the cell, which is known as a viroporine. And what viroporins do is they punch holes into the cell wall, cause potassium efflux, and they also go and activate the NLRP3 system. So viroporin, and for COVID-19 in particular, viroporin 3 is very important. How did we know this? Well, it turns out that viroporin 3 is well known in the pathogenesis of the SARS virus infection. And the genetic sequences that code for viroporin 3 are also found in COVID-19. So therefore, we know that COVID-19, viroporin 3 is extremely important. And in particular, in terms of activating the NLRP3 inflammasome, viroporin 3 is far more important than the spike protein. So you can make as many antibodies as you like to the spike protein. I don't think it's going to do you any good. And in particular, this is of relevance because all of the vaccines that people are making are directed against spike protein, including the Moderna vaccine that codes for the spike protein. So this is very, very important to understand. Now, again, this is the same thing that shows you in a cartoon manner how NLRP3 attaches to what we call the apoptosis spec protein that has got a caspase recruiting domain that activates the procaspase into making caspase that then converts pro-IL-1 beta into IL-1 beta. So this is extremely important, and viroporins are critical to triggering this entire system. So this is a cartoon that explains how viroporins activate inflammasomes, in particular NLRP3. Now, like I said, other viruses have different kinds of viroporins that also do pretty much the same thing. Now, why is this important? Now, what happens in COVID-19, as we have seen, 80% of the people are asymptomatic. Some of the people get sick. They have a viral syndrome, they have fever, but they get better. Some of the people get better with just some mild treatment, and some people get very sick. They land in your ICU on a ventilator. And what these authors have proposed is that the real trick is in how the body controls the NLRP3 system. Now, the NLRP3 system is very, very important because if you don't have NLRP3, you cannot control the viral replication. All right? So NLRP3 is quite important. However, if you have a strong NLRP3 regulatory system, you activate the NLRP3, you control the virus, and then you deactivate the NLRP3, then you have a happy ending because the virus is controlled, you make antibody, you become, quote unquote, possibly immune to COVID-19. Now, there are people in whom the NLRP3 regulatory capacity is not as good, and those people are symptomatic. And then there are people who have very weak NLRP3 control or regulatory systems, and these are the people who really get very, very, very sick. And there is a lot of evidence to support this hypothesis, and we will go over that evidence in a minute. Now, again, remember what I said, COVID-19 activates NLRP3, NLRP3 activates high mobility group box 1 that activates macrophages. By the way, high mobility group box 1 is also the agent that is responsible for a lot of endothelial damage and endothelial inflammation. It also mediates Th17 mediated responses, so neutrophil infiltration and severe damage and cytokine response. So to summarize, what we need to think about with COVID-19 is the central role of NLRP3, high mobility group box 1, IL-1, IL-18, and the macrophage activation syndrome. Now, so of course, there are a lot of people who are trying to figure out how to block NLRP3. And you can try and do that with a variety of different agents. And a lot of these agents, with the exception of glyburide and another agent, which is, it's not on this cartoon, but is another agent that is also an agent that people are looking at to try and block NLRP3, because blocking NLRP3 would be important not in just viral infections, but NLRP3 is very, very important in the pathogenesis of a lot of different things. For example, atherosclerosis, for example, in Alzheimer's disease, and also probably Parkinson's disease. So it is a very, very important inflammasome. Therefore, anybody who comes up with an agent that blocks NLRP3 is going to make an awful lot of money. So again, this is the same cartoon. That what it shows you is that if you cannot block NLRP3 directly, what you can try and do is block downstream the effects of NLRP. And one of the downstream effects of NLRP3 is production of IL-1 by cleavage of IL-1 beta by the caspases activated by NLRP3. And you can block that with anakinra. Now, is that clinically relevant? Now, here is a French study where they used anakinra to block the cytokine storm in a whole bunch of patients, and they showed that there was a clear survival benefit and also benefit in terms of the degree of illness, mechanical ventilation. Very similarly, there is an Italian study. Again, they used high-dose anakinra to show a mortality benefit as well as a morbidity benefit vis-a-vis ventilator use. So, what is seen pathophysiologically has now been proven clinically for IL-1 blockade. We saw how it did for complement blockade, and now we have seen it for IL-1 blockade. Now, next, what else can you do? If you cannot use IL-1 blockade like anakinra, you can use colchicine. Now, what does colchicine do? Colchicine blocks the procaspase after NLRP3 activation. It blocks the activity of NLRP3 in converting the procaspases into caspase, and therefore the production of IL-1 beta and IL-18. And colchicine has been used in other hereditary inflammatory disorder that have the same pathogenesis. For example, familial Mediterranean fever that produces a lot of IL-1 and NLRP3 and NLRC4, and also what we call the hereditary cryopyrin domain fever, periodic fevers, where again the pathogenesis is a lot of production of IL-1 through the NLRP3 system, and colchicine and anakinra both have been used very successfully. But is it relevant to COVID? Now here's a Greek study. They set out to block the cardiac endpoints or the myocardial damage endpoints with colchicine. They didn't quite reach their endpoints because they were looking at troponins only. But they did show that there was a clinical benefit in terms of the illness in people who got colchicine. The people who got colchicine got a lot better, their cytokines were attenuated, and so on and so forth. Now, I will tell you that I've been using colchicine for all of my patients for the last 3 months, and to date, none of my patients has ever landed in a hospital. Now, what else can you do to block the NLRP3 system? You can block it upstream. You can block it by blocking the Bruton tyrosine kinase system with a drug like acalabrutinib, and this has now been used clinically and shown that it has a clinical benefit in people with COVID-19 infection. Once again, more proof that the NLRP3 system is of paramount importance in COVID-19 infections. Now, what else happens in COVID-19 infection? Remember, I talked about the fact that the entire body has all of these receptors. ACE2 receptors are found all over the place. And what we have found with COVID-19 is very early on, it infects the endothelium in the entire body. And just like any other tissue, the inflammasomes that are activated are also activated in the endothelium. You get a lot of endothelial damage. And when you get a lot of endothelial damage, you get vascular leakage. But in particular, you get a lot of leakage of the clotting system. So there is an endotheliopathy. And in this paper, you can see that compared to people who are in the ICU versus non-ICU, the ICU ones are all in the red. And whether you look at antiplasmin activity, platelet activity, D-dimer activity, thrombin activating activity, von Willebrand antigen or von Willebrand activity, and factor VIII activity, is a huge difference. And this is of critical importance to understand because very early on, everybody who gets a COVID-19 infection gets a diffuse infection of the entire endothelial system. And for those people who are not able to block the inflammatory cascade, they go on to develop hypoxemia because of the vasculitis. In particular, the happy hypoxemia is because of pulmonary vasculitis. And very early on, many reports stated that a lot of these people were getting platelet thrombi, not only in the pulmonary vasculature, but also in the arterial system, in the central nervous system, and in other places. So very clearly, very early on, these people are getting platelet aggregation and platelet thrombi. And this early platelet aggregation, platelet thrombi, is resistant to the action of usual anticoagulants, including heparin. So it is very important to understand that this early vasculitis is very important to attenuate, and the high mobility group box 1 is a key mediator in this kind of vasculitis. Now, what is very interesting is the effect of von Willebrand factor. When you have all of this endothelial damage, you get massive production of von Willebrand factor multimers and oligomers, and these then attract platelets, and they form platelet thrombi to begin with, and then finally they activate the collagen and activate the thrombin system, and eventually you are going to get the traditional usual clots, which have red blood cells, white blood cells, platelets, the whole 9 yards. And by the time you get to that stage, you will need to use traditional anticoagulants. By the way, heparin is one of the things that probably will block to a certain extent the high mobility group box 1 along with statins. So this is the other reason why both heparin, whether it's low molecular weight heparin or statins, probably have a very important role to play in attenuating the consequences of the diffuse vasculitis in COVID-19 infections. Now, this is again a cartoon that shows the same thing. You have inflammation, pro-inflammatory cytokines that inflame the endothelial cells to produce a lot of von Willebrand factor. Now, if you have enough ADAMTS13 around, it will control the amount of oligomers made by von Willebrand factor, and it will control the amount of platelet thrombi that are formed. Unfortunately, when you have excessive release of von Willebrand factor, you overwhelm the native ADAMTS13, and you will go on to produce these platelet thrombi and actually activate what we call the netosis or neutrophil extracellular traps that I talked about in the beginning of the talk. And then you have the usual classical thrombus. So this is the sequence of events that occurs in a lot of patients with COVID-19 infection because they get a diffuse endothelial infection and a diffuse vasculitis in the entire body. No organ is spared. Now, what can you do? Now, you can use N-acetylcysteine. Now, N-acetylcysteine we always thought was, something that reduced oxidative stress by giving sulfhydryl bonds and blah, blah, blah. It turns out that's not the real reason why N-acetylcysteine is of utility in COVID-19 infection. What N-acetylcysteine does, and this is shown both in human models as well as in animal models, it reduces platelet aggregation. It reduces binding to collagen. It reduces the size and activity of von Willebrand factor in human plasma as well as in mice. Now, it also reduces the amount of collagen and platelet aggregation in a dose-dependent manner. And most importantly, it also helps to resolve the thrombus by allowing ADAMTS13 to act unopposed. So if you look at those animals where you give them a lot of N-acetylcysteine, it'll work. Now, interestingly, even when you don't have any ADAMTS13 around, N-acetylcysteine still works to reduce the size of the thrombus and also to reduce the amount of time required for resolution of the platelet thrombi. So again, the other interesting thing is we intuitively think if you're going to reduce platelet binding and platelet aggregation, you'll increase bleeding. Well, very interesting. N-acetylcysteine does not increase platelet, does not increase bleeding times, at least in mice. So N-acetylcysteine, I think, has a very interesting role to play in the supportive management of COVID-19 infections. Now, let me come back to why corona infections are not lethal for bats. Now, I remember I said that part of the pathogenesis of COVID-19 in humans is that COVID-19 produces the viral viporins, viporin 3 in particular, that punches holes in human cells or mammalian cells. Not only that, the viporin 3 activates NLRP3 that produces a severe inflammatory reaction and leads to pyroptosis. Now, very interestingly, in bats, they don't have this ability to make this viporin-mediated severe inflammatory reaction, because the viporins in bats do not cause pyroptosis. They cause apoptosis, which is a clean death of the cell, and after that it is scavenged. The difference between a viporin-induced apoptosis and a viporin-induced pyroptosis is that in pyroptosis you have massive activation of NLRP3, and then the NLRP3 induced cytokine-mediated damage through all the DAMPs and PAMPs and so on and so forth. And in this report you can see that in red are the bats, and in the bats, no matter what you do, whether it is lipopolysaccharide or other triggers of NLRP3, the amount of NLRP3 that is activated in bats is dampened. And this is the reason why we think that bats can easily manage all of the coronaviruses, and they can transmit that coronavirus to another species where the viporins will activate NLRP3, cause massive activation and a pyroptosis. Again, another ancillary piece of evidence that shows us why NLRP3 is so central to the pathogenesis of COVID-19 infections. So what are the implications of understanding all of this pathophysiology? And what I would suggest is the reason why SARS-CoV does not cause a problem in the majority of infections it infects is that the majority of humans, just like bats, are able to attenuate the NLRP3. And in all humans, the viral replication is eventually controlled. So just viral replication is not relevant. Okay, viral replication may be relevant only in the early stages. But in a minority of individuals who get very sick, there is the NLRP3 which is activated and not controlled, and this is something that mimics the hereditary inflammatory disorders like familial Mediterranean fever or the cryopyrin-associated periodic syndromes like the familial cold-induced autoinflammatory disorder, Muckle-Welch syndrome, or the neonatal onset multisystem inflammatory disorder. These are disorders that we don't see in adult medicine, only pediatric rheumatologists see it. Now, very interestingly, Kawasaki's disease has been reported in young people with COVID-19 infection. And the severe multi-system inflammatory disorder has been reported in young people. And once again, NLRP3 is of major importance in Kawasaki's, which is why Kawasaki that has been refractory to treatment with high-dose immune globulin has responded both to colchicine as well as anakinra. So again, that is additional evidence that NLRP3 is of central importance in all of these different presentations of COVID-19 infection, where NLRP3 overactivation and lack of control is central to the pathogenesis. So systemic vasculitis is very central, and all of these initial stages, platelet aggregation is very important, platelet thrombi. And the initial platelet aggregation, platelet thrombi cannot be controlled by direct acting anticoagulants. They may be controlled to a certain extent by low molecular weight heparin, but they'll be controlled much better with N-acetylcysteine. And in late stages of COVID-19 disease, the lung injury and the kidney injury is actually mediated by the terminal attack complex of complement, which is downstream all of the cytokines, including tocilizumab. So if you have somebody who has ARDS and is on a ventilator, who has renal failure, is requiring renal replacement therapy, the only agent that might potentially help you is actually blockade of complement by C5 blockade, eculizumab. So what is my personal approach to patients? I look in everybody for markers of inflammation. I do a symptom screen, of course. If they are asymptomatic, wonderful. But if they have symptoms, I look for lymphopenia, I look for high CRP, I look for high LDH, high ferritin, oxygen saturation. If their oxygen saturation is low, look for D-dimer, look for evidence of thrombotic microangiopathy. In early stages, I think colchicine, N-acetylcysteine, and famotidine are my anchor. If possible, an antiviral, particularly if they have come in the very early stages of infection. Later on, I'm not sure what the antiviral will do. In somebody who has moderate illness beyond mild stages, I think we should add dexamethasone and atorvastatin. In people who are hypoxic, I certainly think you should think about whether or not anakinra would be of added benefit. You should certainly use famotidine and acetylcysteine, atorvastatin, dexamethasone, and if D dimers are high, rivaroxaban. Now in refractory hypoxemia, these are the people which I think have terminal organ damage due to the terminal attack complex of complement. We really should be looking at eculizumab. Now will these people be helped by replacing complement control proteins or replacing ADAMTS13, which is the von Willebrand factor proteases that you can get with fresh frozen plasma, is a question that needs to be answered. Anecdotally, we have used fresh frozen plasma in some people with some benefit, but I cannot tell you that I have evidence that this will work. Okay? So that's all I had to say. If you have questions, I will take questions and I will answer questions. Once again, I want to remind you that this entire presentation is on my website on www.happenfor1health.org, and you are welcome to download it and look at it. I also have some other of my commentaries on COVID-19 with a lot of references. If you're interested, you're welcome to download it and look at it. So I'm happy to take questions.
Thank you very much, sir, for an exhaustive talk. It was a bit long, but I think it was required to understand a lot of things actually which we had in mind. So there are so many questions, but we'll take up a few questions. There are some questions from our team members as well as from the audience actually. The first question which I have in my mind is, a lot of people now come with hypoxemia. Only the people who are having hypoxemia are getting admitted. Other people who are mildly symptomatic, non-hypoxemic, actually we are trying to manage them at home. So when these hypoxemic patients are admitted to the hospital, we are starting them on dexamethasone, as you said. And after we spoke to you last week, we have started adding N-acetylcysteine and colchicine. So will there be, first question is, will there be any interaction of adding colchicine and steroid? And second question is, at this time when the patient is hypoxemic actually, so should we add remdesivir or not? Because at least in the, according to the current thing, the remdesivir is being added in patients who are having a saturation less than 94%. And people who come to hospital are hypoxemic. So these are the two questions in mind, and then I'll allow Dr. Jagadeesh and Dr. Deepika to ask you questions.
So let me take this one at a time. So I have actually given several patients dexamethasone as an outpatient whenever they have been persistently symptomatic or their oxygen saturations have drifted closer to 90 or started drifting below 90. And so far, all the patients that I've given dexamethasone to, they have stayed out. I give dexamethasone to everybody. My anchor to start with is colchicine and acetylcysteine and famotidine, and that seems to be working just fine. Now, I think that you know, in how to adding remdesivir or favipiravir, I think that I don't have the answer to that question. We need to wait for large controlled clinical trials data to come. Mechanistically, I think that the benefit would be marginal, if any, because antivirals work only in the very early stages of infection. By the time the patient has come to you, I would suggest to you that their viral load is actually already declining. And at that stage, the only thing that will help you is the anti-inflammatory. Colchicine interaction with other drugs is really irrelevant, except if you use a potent inhibitor of cytochrome P450. In that case, I would cut the dose by half. Otherwise, there is no significant drug interaction that is clinically significant.
Okay.
Yep. Sir, this is Jagadeesh. Sir, coming to the asymptomatic patients, so we have lot of patients who doesn't even have the mild illness. So I categorize my patients into asymptomatic positive and asymptomatic suspects. So either of these two cases also, should I start the 3 drugs, or should I wait for the report, or should I wait for the illness to set in?
So I don't wait for any report. The problem with waiting for the virologic testing is it can range from a few hours to a few days, and you lose the window of opportunity to
Sure.
intervene. So anybody who is symptomatic, I absolutely start them on treatment. The question is what to do with asymptomatics. Now in asymptomatics, I think that in people who are old, people who have pre-existing diabetes or hypertension, kidney disease, liver disease, whatever, I think you should screen them with CRP, LDH, ferritin, and if those markers are high and they are lymphopenic, I don't wait for symptoms. I will start them on colchicine, famotidine, and an acetylcysteine. Because even in quote unquote who are currently asymptomatic, what you don't know is, are you seeing them in the 48 to 72 hours before they are going to become symptomatic? And also you cannot predict who will crash and burn and how fast.
Sir.
So even in asymptomatics, you should screen them with the markers for inflammation,
Fine.
particularly if they are at high risk. Young people, no illness, they're perfectly good health, they're asymptomatic, I just tell them to watch it.
Okay, sir. What is the role of favipiravir in this particular early onset
So the only data we have for favipiravir comes from small studies that showed some benefit. Again, like I said, mechanistically, I think that the favipiravir benefit will only be in the early stages of infection.
Sure.
But there is an ongoing clinical trial that is still enrolling patients. I think that trial is coming to a close, which will be, that trial will, hopefully that data will come out soon. And that will tell us how good favipiravir is or what the benefit of favipiravir is. Because in that trial, they are looking at favipiravir versus quote unquote standard of care, where the standard of care very often was hydroxychloroquine and steroids and multivitamins and so on and so forth.
Sure. And coming to, is there any one single lab parameter or clinical feature which hints us the poorer outcome or a trigger of cytokine storm?
Ferritin. If your ferritin is high, you are destined to have trouble.
Any clinical feature you have noticed, sir?
What I look for, particularly in young people, is a bad rash. Okay?
Rash.
Because young people who have the multi-system inflammatory disorder, particularly if they have a bad rash, they are having something akin to Kawasaki's. And we know that this virus causes a vasculitis, and in fact, coronary vasculitis with COVID-19 has been reported. And those people, I don't think colchicine and anakinra will suffice. They will need very high dose IVIG. Because there we have to use massive quantities of antibody to block every receptor on earth.
Sure. Is it the only severe illness where I have to chip in anticoagulant, or even for moderate illness also? And why only oral anticoagulant?
Because it's simple and easy. Now, the thing that I think you should look for is D-dimer. If your D-dimers are high, you have to intervene. So whether you use heparin or you use rivaroxaban is up to you. I think the added advantage of heparin is that heparin will block high mobility group box 1, which we know is very important in vasculitis. Whether rivaroxaban does anything like that is unknown, probably not.
Because coming
but
to the
rivaroxaban, the advantage is it's oral, so you can send them home.
Fine.
This is Deepika here, sir. So, sorry, it's on.
Yeah, you can.
Yeah, I can hear you.
Yeah, sir. My question is, since viral load predicts the progression of the disease, would adding cyclic threshold values be helpful in guiding the treatment management plan?
Now, you must make a distinction between cause and effect and association. So if you look at the people with mild, moderate and severe illness, there is an association with severe illness and a higher viral load. Okay? But in everybody, whether you use mild, moderate or severe, as time goes on, their viral loads decline, regardless of their clinical outcome. Even in people who die, their viral loads decline. Now, what is the utility of looking at CT values, okay, cycle threshold values?
In the initial part of the diagnosis, sir, would it help?
Yeah, the initial part, it just tells you if your CT is very low, certainly below 30, that you have a high viral load, okay? And there is a published paper that tells you the formula to use in converting CT values into actual viral loads. It's a rough approximation, not very accurate, but you know, again, like I told you, it is not the virus. We have kept on deluding ourselves into thinking it's a virus, it's a virus, it's a virus. No, no, no. It is the viroporin that the virus has that activates NLRP3. So focus on NLRP3, 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 and NLRP3. Everything else is irrelevant. The entire world in COVID revolves around NLRP3. And if you have come to the stage where NLRP3 has already done all the damage, the only thing that can help you is eculizumab. It's a little bit like this. You see, a thief has entered your house and put your house on fire. Now you have two choices. You can call the police or you can call the fire engine. What are you going to do?
Fire engine.
Fire engine.
Fire engine.
Correct. That's the point. So, look, I always like to tell my trainees in infectious disease, particularly in transplant infectious disease, don't focus so much on the antibiotics and all of this garbage and which scan to do and what to do. Focus on keeping the patient alive. Okay? And in transplant infectious disease, if you don't keep the allograft functioning, you lose the patient. And please understand, it's very difficult to treat infections in a dead patient.
Sir, I have one question about steroids. In your algorithm, you have mentioned that you add dexamethasone in the moderate subset of diseases. Even in our clinical practice, we start using dexamethasone steroid in moderate cases when they start having hypoxemia. So, do you suggest using steroids in people who are not hypoxemic,
Milder.
but are at a higher risk of developing complications like comorbid conditions, and people who have elevation of inflammatory markers like ferritin or some other inflammatory marker like LDH? So would you suggest adding steroids in patients who are not hypoxemic but at high risk and with raised inflammatory markers?
So I think I don't have evidence to support what I'm saying, but mechanistically, if you think what is the most important thing that you need to block, and dexamethasone is your best agent there, that is the macrophage activation syndrome. Now, like I said, you should have a high index of suspicion for macrophage activation syndrome. If you're going to ask for only one marker, you'll probably miss a few. Ferritin, of course, is very helpful, but rather than look at the absolute value of ferritin, you should look at the relative values of ferritin. If somebody comes in with an okay ferritin, less than 500, okay? And now a couple of days later, they're hypoxic and their ferritin has gone up to over 500, but still below the magic number of 800. That person has macrophage activation syndrome. And we know this from the data from juvenile rheumatoid arthritis, systemic juvenile rheumatoid arthritis, and also Still's disease, because this is one hereditary inflammatory disorder where they get very frequent macrophage activation syndromes, and their ferritins are not necessarily higher than 800. They are higher than 500 only. Okay? So the relative increase in ferritin is very important. I think the relative increase in LDH is very important, because if your LDH is suddenly going up very high, don't sit and wait for schistocytes to appear. They're very difficult to find. You need to be a very skilled hematologist to look for schistocytes on a peripheral smear. Rest assured that somebody whose LDH is going up very high and they're hypoxic, they have thrombotic microangiopathy, and they probably have macrophage activation syndrome. Those are the people that I would add dexamethasone. So in anybody who has all of these markers, I'm not going to wait for the inflammation to burn down the house before I call the fire engine.
And sir, one question regarding the choice of steroids, because there is a wide variation in the practice of the steroids. Some people use dexamethasone, some people use methylprednisolone. So what is your choice of steroids, and will there be any interaction if you are using it with remdesivir? Interaction of methylprednisolone with remdesivir or dexamethasone with remdesivir?
Not in the doses that we are using, and it really doesn't matter. See, even remdesivir is not a super potent antiviral agent. Okay, a little higher level will not hurt you. Same is true of favipiravir. A little higher level will certainly not hurt you. Both remdesivir and favipiravir cause hyperuricemia, so you have to watch out for that and you have to manage that. Okay. The reason I prefer dexamethasone over methylprednisolone is, firstly, dexamethasone is a better anti-inflammatory agent amongst all of the steroids. And secondly, methylprednisolone is certainly more immunosuppressive than dexamethasone is. Okay, at least in the doses that we like to use. Okay, so that's why I don't, I say, look, use dexamethasone, but even dexamethasone, use it for the shortest period of time possible, because you are going to eventually run into trouble with the steroid effects of dexamethasone, and whatever you gain in the anti-inflammatory effect will be negated by the immunosuppressive effect.
So I have one question, sir. So except for a few patients, and most of the patients after initiation of steroids, what we are seeing is there is significant decline in the IL-6 levels. So at that point, even if there's a clinical deterioration, would tocilizumab help or anti-IL-6?
Well, I presented to you at least one opinion where the author suggests that tocilizumab is completely irrelevant because IL-6 is irrelevant. So I don't know the answer to your question. But what I would suggest to you is that, A, it makes no sense to use tocilizumab in the later stages of illness. You know, when you already have severe lung injury and severe kidney injury, that is not the time where you should be blocking IL-6, because what you are dealing with is all the downstream effects of IL-6 activation. And the levels of IL-6 we are talking about in our patients is ridiculous. They are irrelevant. So unless you tell me that you have a patient whose IL-6 is in the several hundreds that we are used to seeing in septic shock and ARDS, I wouldn't get too excited about IL-6 levels. And mechanistically, if you want to use tocilizumab, it should be way before somebody gets on a ventilator, because that's when you will block the downstream effects of IL-6. All right?
Sir,
so I think we are using we are not using tocilizumab in the right place, and we are using too much of it in the wrong place.
Fine.
And by the way, before you use tocilizumab, you should have checked your patient to make sure that they are not at risk for reactivating hepatitis B, hepatitis C, tuberculosis, cytomegalovirus, and all of those things. And trust me, you will see more bloodstream infections with Candida and bacteria if you use tocilizumab. It is a rather potent immunosuppressive.
Sure. So coming to dexamethasone, is it the same dosage, 6 mg, what you are going to use, or it depends upon the illness, sir? For mild, certain dosage, moderate, certain dosage, and severe.
See, what you have to understand is all steroids, we always make a distinction between an anti-inflammatory dose and an immunomodulatory dose. Okay, as you know, there is no advantage to using more than, say, 6 or 8 milligrams or 10 milligrams of dexamethasone, or 60 milligrams of prednisone, or say, 30 or 40 milligrams of methylprednisolone a day in terms of the anti-inflammatory effect. Okay.
Fine.
What you buy with a higher dose is the immunomodulatory effect.
Yep.
So in my transplant patients, when I'm treating rejection, particularly if I'm trying to treat humoral rejection, I might use methylprednisolone, but I use industrial doses. I use 500 milligrams to a gram daily for 3 days. Okay, though that's a immunomodulatory dose. Doing anything less than that is, what we call half-assed efforts. So either you use it or you don't use it, because no matter what we do, the first thing that we are looking for is looking for impact. And we judge the efficacy of our intervention by impact. So either you use it in an impactful dose or you don't use it, because otherwise you will not be able to interpret what on earth is going on.
Fine, sir. So,
I have another question, sir. in few of the patients who improve and then go home, we're seeing them coming with another rise in the inflammatory markers, what we call as delayed cytokine storm. So
No, it is not a delayed cytokine storm. Please understand what is happening with COVID is they get a diffuse vasculitis, okay, and they get an activation of their NLRP3 system. And you cannot assume that by just giving them 7 days or 10 days or 14 days of whatever treatment, you're going to switch everything off. The treatment duration has to be tailored to what's happening with the patient. And this is the reason why we've had a lot of patients in the early days who we said, now you're cured, you're out of the ICU, you go home. They went home and 3 days later they keeled over because of acute pulmonary embolus. And we've had lots of patients who are struggling at home because they are severely fatigued, they have severe anorexia, they cannot eat, they cannot do anything. And we have looked at their inflammatory markers, they're very high. LDH is high, CRP is high, ferritin is high. So I don't stop giving people treatment unless I'm convinced that their inflammatory syndrome has been switched off, number one. And number two, in some people, even if they symptomatically are better, I have repeated their LDH, their CRP and their ferritin and their lymphocyte count to be certain that those are all okay before I stop giving them colchicine, famotidine and N-acetylcysteine. I think that in people who have had high D-dimers, it is a mistake to withdraw the rivaroxaban or the heparin prematurely because they will die. Very clearly, a lot of these people have occult myocarditis, occult vasculitis, and unless you actively look for them, you're going to miss it. And the best agent to use for these people is famotidine, colchicine, and N-acetylcysteine. For some of my patients, I've given it for 3 weeks. All right? And
So
some of my
what-
patients, I've told them that even at the end of 3 weeks, I'm not sure that I will stop it.
Okay. So for how long should we be giving the anticoagulation in severe
3 months to 6 months.
severe
Well,
patients?
I think that you can use the data from a provoked VTE to guide you, and there it is quite clear that after 3 months of anticoagulation, there is no benefit. So certainly you can say, well, this was a provoked event,
Provoked event.
and therefore 3 months should suffice. But at the end of 3 months, I would suggest that you look for the markers of
Markers
CRP, LDH, and maybe we should also be looking at von Willebrand factor levels, because I showed you that study where clearly von Willebrand factor antigen was above the upper limits of detection. It was sky high, very, very high. So there's, you cannot predict. And some of these people, by the way, some of these people, I neglected to mention this, have antiphospholipid antibodies. So you be careful there. You want to look for that also. You want to look for antiphospholipid antibodies. You want to look for evidence of complement consumption, their C3, C4 levels, before you decide it is safe to discontinue rivaroxaban.
Sir, there is a question from a nephrologist who is asking whether colchicine is recommended in patients who are having chronic kidney disease or who are already on dialysis.
It is safe to use. In the doses that we use, it is safe to use.
Okay.
And people have advocated the use of colchicine in every kind of vascular disease because it attenuates NLRP3, which is very, very important in atherosclerotic disease. And as you know, a lot of our people on dialysis have severe atherosclerotic disease of their renal arteries because of diabetes and hypertension.
Any questions? Any more questions?
Sir, coming regarding the three drugs what you have been using for the past 3 months, did you notice any adverse effects with the patient, sir, reporting within a couple of days or weeks? I mean to say colchicine, famotidine and mucinex.
What was the question? I couldn't hear the question.
So the 3 drugs, colchicine, mucinex and N-acetylcysteine and famotidine, the 3 drugs whatever you have used, did you ever noticed any patients coming back with any side effects with these 3 drugs?
Coming back with what?
Any adverse effects or side effects, sir?
Or adverse effects. Well, colchicine in some people will cause diarrhea. So
Diarrhea.
if that happens, you cut the dose.
Any
And they're
bad
able to
headaches,
tolerate
sir?
it just fine. With the low dose colchicine that we give, which has been given to literally hundreds of thousands of people, there's very, very rare side effects. You see, the early days we used to use very high dose of colchicine that caused marrow failure. In fact, that is the reason why intravenous colchicine was withdrawn from the market. It's banned.
Fine, sir.
Because people got a very high dose of colchicine and then their marrow failed.
So-
So, in the low dose of colchicine that we use, less than a milligram a day or 1 milligram a day max, the side effects are quite tolerable. And we are using it for a limited period of time. In fact, colchicine has been used for long-term use, including in children in familial Mediterranean fever,
Yes.
without any significant problems. So,
Sir, is there any
half a
loading
milligram
dosage,
twice
sir?
daily has been safely given, including to children, women, pregnant women, everybody, for years together without any side effects.
Sir, do you recommend any loading dosage of colchicine, sir? Just it was
What?
used in loading dosage of colchicine,
No. Never give loading doses of colchicine. That is a mistake.
sir.
That is what causes the diarrhea.
One of
In
the
fact, even for gout, we no
cardiovascular
longer
trial.
use loading doses. So we use low dose colchicine along with a little bit of prednisone to treat gout. So colchicine loading doses are never used anywhere.
In one of the
And
cardiovascular trial,
famotidine and the N-acetylcysteine, their side effects are virtually very mild and really these are very well tolerated agents, so nothing really to worry about. And like I showed you, N-acetylcysteine doesn't even prolong bleeding time. So
so the same
whatever
are the same
platelet
drugs.
effect it has is not clinically significant. And in fact, now people are using N-acetylcysteine for vascular injury. Particularly the US Army is using it a lot for brain injury patients to attenuate neurovascular injury. So
are
both
this-
colchicine and acetylcysteine have been used in a lot of vascular disease with good effect. And colchicine, as you know, is being used for attenuating reperfusion injuries and heart disease also.
So are the same drugs can be used in pediatric age group also, sir?
In what other cases?
The same drugs can we use in the pediatric age group also? People who turn to be COVID.
Pediatric cases, yes. I see no reason why there is any contraindication because, like I said, we've been using colchicine in children for many, many years now.
Exactly.
And famotidine has been used safely in children, as has N-acetylcysteine. I mean, we poured N-acetylcysteine by the kilogram into our septic patients, right?
Sir, has this combination been prospectively studied, N-acetylcysteine, famotidine and colchicine? Because I might have missed in the literature which you have told. Has it been...
Not that I'm aware of. There's no published data on it yet. But a lot of people are trying it.
trying this? Okay.
Thank you.
Any other questions? And thank you very much again for accepting our invitation and giving us so much of insights about COVID-19, sir. Thank you very much.
Enjoyed it. Thank you.
Yeah.